My name is Peter Kokkinos, Professor of Medicine and Director of the Cardiometabolic Unit at the Veterans Affairs Medical Center in Washington, D.C. The title of my presentation is Clinical Significance of Exaggerated Exercise Blood Pressure, presented at the International Academy of Cardiology Annual Scientific Meeting 2017 in Vancouver. During physical work, systolic blood pressure increases proportionally to the workload and plateaus at approximately 200 millimeters of mercury, while diastolic blood pressure remains stable. However, in some individuals, the rise in systolic blood pressure is disproportional to the workload. Systolic blood pressures greater than 210 for males and 190 for females is considered to be an exaggerated blood pressure response to exercise. Such a response has been associated with increased incidence of hypertension, left ventricular hypertrophy, and cardiovascular disease morbidity and mortality. In a cohort of 790 pre-hypertensive individuals, we noted that the systolic blood pressure at the workload of less than 5 meds and the daytime systolic blood pressure were very similar. Since the metabolic demand of most daily activities is less than 5 meds, we hypothesized that the systolic blood pressure response to this workload may be an indicator of cardiac structural and functional changes. Indeed, in the aforementioned cohort, we noted that the systolic blood pressure at the workload of less than 5 meds was the strongest predictor of LVH. The likelihood of LVH increased fourfold for every 10 millimeter increase in systolic blood pressure beyond the threshold of 150 millimeters of mercury. Over 86% of those who achieved and exceeded that blood pressure were correctly identified as having LVH. We also noted that the age-adjusted exercise capacity of individuals with an exercise systolic blood pressure of less than 150 millimeters of mercury was significantly better than those with a systolic blood pressure greater than 150 millimeters of mercury. When we stratified the cohort according to the fitness status, we noted that the systolic blood pressure response to exercise and the prevalence of LVH were significantly higher for individuals in the least fit category compared to those in the moderate and highly fit categories. Subsequent interventional studies by our group support that increased physical activity that results in improved cardiorespiratory fitness attenuates the systolic blood pressure response to exercise and leads to LVH regression. Interventional studies by our group support that improved cardiorespiratory fitness attenuates the systolic blood pressure response to physical exertion and leads to LVH regression. Our findings support the following conclusions. 1, a rise in systolic blood pressure of more than 150 millimeters of mercury during the workload of less than 5 meds is a strong predictor of LVH. 2, since the workload of less than 5 meds reflects the metabolic demand of most daily activities, it is likely that a daytime systolic blood pressure of greater than 150 millimeters of mercury is the impetus for LVH. And 3, increased cardiorespiratory fitness attenuates the systolic blood pressure response to exercise or physical work, and this leads to lower likelihood of LVH. In addition, it leads to LVH regression when LVH is present.